will take on his moderating role. So we have an excellent panel lined up today to make important contributions to the topic of data for health. Before I introduce them, let me just give you a very brief overview from the Commission on this important topic. Clearly, this is an exceptional year to review the role of data for health. We've all seen that COVID is having a huge impact on our society and placing our health and care systems under immense strain. So there's an imperative to learn lessons and to understand what could be done better in many areas, not least in data for health. So if we could have the slides up for, I think we have some slides available on my side. Thank you. And to the next slide. Wonderful. So it's clear that the Commission is very engaged in data and understands the need to make it more accessible and to have a better flow and to bring the benefits of the digital technologies such as artificial intelligence to the health and care. And of course, we know what this means. This means that health gets to benefit from the next generation of treatments. We have news about personalised medicine, the next generation of health and care tool, use of robotics in health and care. It can also help us manage our health and care systems, help them to meet the challenges of ageing and the issues around sustainability in our systems. And the hope is that that will ease the path for the future. So, but to make this work, we need to help the data to flow in order to take it forward and test it and create new technologies in the field of, for example, mHealth, medical devices, and so forth. And that this is the reason why the Commission came forward with a data strategy earlier this year. And of course, health is a particular kind of data. It's a very sensitive kind of data. And for this reason, the emphasis has got to be also on not just making it accessible, but to make it accessible in a way that citizens can trust. So this means building in safeguards in relation to data protection, cybersecurity, and privacy. So the next slide, please. So of course, COVID-19 has given a particular urgency to the use of health data. We've worked very closely and intensively with member states to rapidly review what kind of digital solutions can support the pandemic response. And the most high profile of these, which I think most people will be aware of, is the work we've done with member states on mobile contact tracing apps, where we've worked with member states to develop these apps in a way that citizens can appreciate, that are effective, and essentially that are interoperable, because of course as citizens move around the European Union, it's essential that they can continue to use their national app as they move. And the view is that the hope is that these are making a valuable contribution above and beyond the traditional classical contract tracing techniques. So to date, we have 15 member states with apps functioning and another 4 in development. And again, the hope is that these will play a vital role in helping societies return to normal life. Luckily, when the COVID pandemic started, we already had a strategy in place. And we knew the value of health and healthcare data, and this was a strategy that we launched in April 2018, which is on the digital transformation of health and care. But COVID, of course, has brought this value into very, very sharp relief, very sharp focus for us all. So in the communication on digital transformation of health and care that was launched in 2018, of course, we envisioned a range of actions, a range of objectives. I'll just point to one of those, for example, which is the objective to make health data more accessible, to make it more available for researchers and innovators, and to underscore and emphasize one particular initiative that we're carrying out, again, very closely with member states, which is the use of, to improve the use of genomic data. And here we have a process ongoing that hopes to see 1+ million genomes accessible in the EU by 2022. More recently, with the arrival of this Commission, there has been a new political imperative, which is to create a European health data space which can underpin the digital transformation of health and care. And this is a goal that is in the mission letter of Commissioner Kyriakides. And here we're talking about a number of actions that are needed. We need to support member states to continue with their work to digitize health and care records. We need to support the development of capacity across health and care systems, for example, in terms of data storage and data analytics and skills. This means work to help link data sets across regions and countries, and to link different kinds of data sets that are valuable for developing the digital transformation of health and care. So this is an exercise also in putting in place the right infrastructures and the appropriate governance structures. And the Commission very much sees that the it's the role of the infrastructure that can really help square these objectives around both, on the one hand, making health data accessible, and on the other hand, ensuring that it is secure. Health is one of a number of data spaces. I think if you can leap forward a couple of slides to one on the common European data spaces. The Commission foresees a number, and health is, of course, is a critical priority. All of these data spaces will have overarching frameworks in common to them. So we have, for example, the GDPR, of course, the cybersecurity frameworks, for which a key aspect is the NIS directive, and privacy frameworks. And they will also have common technologies, and a common infrastructure is envisioned, co-funded by the Member States and the Commission to support these. And access as well to common public goods that will help exploit and use the data, for example, in the form of high-performance computing, for which the capacity is being developed across the EU. And a key foundational across all data spaces is very much about the interoperability. And this is particularly critical in health. We need to be able to find a way to have data link across within a healthcare region, between healthcare providers, across borders. And here we have started this work, and we've developed specifications for sharing patient records and e-prescriptions. But now we've just started a program earlier this month called eHealth, which will take this work further into new health domains, lab tests, hospital discharge records, and medical images. And we'll see these new technical specifications developed, and then of course it's essential that these are taken up and we promote these across the EU. This is just a rapid run through of the work going on in the EU. The last thing I want to mention is the concept of testing and experimentation facilities. So this is critical when we have established some mature data sets, to make them available, to find them securely, make them securely available to actors across the research and innovation field who can access this data, combine it with artificial intelligence, combine it potentially with the physical resources also they need to do the final testing of their products before they can be safely and effectively integrated into health and care systems. So this is a concept that we're exploring at the moment across a range of sectors, including in health, which we think will be part of the puzzle to then really be able to work with the health data that's becoming available. This is a rapid run through from my side. So now it remains for me to introduce this excellent panel that we have today, and I'm very excited to listen to their contributions. We have 4 speakers. The first speaker is going to be Helen Johnson, and Helen Johnson is an expert in mathematical modelling at the European Centre for Disease Control and Prevention. Of course, she's worked across a range of different diseases, but her focus in 2020 has very much been COVID-19. We then also, I'd like to welcome Mr. Nicholas Blomberg, and he's the Director of Elixir, and this is an organisation that is coordinating and developing life sciences across Europe. We will also have Ms. Annette Madi-Nator. She is Director of International Operations and Cyber Services. She's held senior positions in the Hungarian government, and she's had extensive engagement with NATO on these topics. And lastly but not least, we have Milan Petrovic. Now he leads the A&I Data Science Department at Philips, and he's also a part-time full professor at the Eindhoven University of Technology in the field of computer science. So thank you very much. This is a brief introduction. We'll have the speakers now, and then after there will be time for discussion. So if I could hand the floor to Helen Johnson.
Thank you very much for that introduction. And if it's possible to bring up the slides, that would be helpful. Otherwise, I can share. Thank you very much. So as was introduced, I am a mathematical modeler, which means that I find ways to simulate the spread of infectious diseases. So 2020 has been a remarkable year for all of us, but for infectious disease modelers, it's proposed new challenges. But I would say in response to Kerry's introduction that it has also helped us to jump ahead with some of the things that we've been planning to do for some time, or that we had ideas about. the ways that we incorporate data into our models. Next slide, please. So mathematical modelling can be used to make forecasts or predictions of disease, or to understand the dynamics of infectious disease. It's very helpful for quantifying uncertainty and giving guidance to policymakers. But in one level, it's a way of incorporating different disparate data sources. So learning from different sources and different data streams together, bringing them together in a way where you can account for bias and you can tell a more complete story. So the European Centre for Disease Control, ECDC, makes 30-day forecasts for each member state of the European Economic Area and for the UK, predicting the number of confirmed cases of COVID-19 over time, the number of deaths, for planning of preparedness and response. We look at hospital admissions, ICU admissions, and the occupancy levels in hospital ICU. We use a dynamic model to do this based on differential equations, and we calibrate it to data that we can observe. So what has happened up until today, what we can say so far. We do that with, for those who are interested, with adaptive MCMC. But the sources of data are very disparate, as I said. We have a number of, there are a number of measures, incidence of diseases, which are reportable to ECDC from every member state. And in fact, in many cases, there's someone in a national public health institute who is checking those databases and then submitting it. We don't yet have computer-to-computer transfer of that data because of the security issues there that might be of interest to you. But in the case of SARS and SARS-CoV-2, there was no precedent. There was no agreement on how that data would be shared. So in February, March, that had to be set up, the submission of that data to the database for this new virus. We also take data from public health institutes, other data that they may have. We need to incorporate various assumptions about the rate of progression of disease from the scientific literature. We have done a lot of web scraping of data to work out how many deaths, how many cases there have been at subnational level. We found at the beginning of the pandemic that the best way to get the information quickly was to scrape it straight off the Public Health Institute's websites and then ask them to validate what we had obtained for ourselves, because it was such an acute crisis situation that many didn't have the time to set up new systems for submitting to us. We use media reports to inform on the response measures in place in different countries, and we validate what we learn from the model against mobility data from telecoms companies, and we're very keen to include some of the data too from the contact tracing apps that Kerry referred to. Next slide, please. So as I say, we need to look at the progression of the virus infection to disease. We do that largely from the papers which are being published in the scientific literature. And then we web scrape all the data that we can on hospital admissions and on the number of tests being conducted in each country. Then we go back to member states and we check, are you happy with the numbers that we have obtained? Next slide, please. The model includes 4 types of non-pharmaceutical interventions based on physical distancing. We model the cancellation of mass gatherings, the closure of public spaces, and recommendations and orders for the general population to stay at home. This informs how much people come into contact with each other. We also simulate the use of face masks, and we assume that if you are wearing a face mask, it makes you less susceptible to infection, but it also makes it less likely that you will pass on that infection. Now, all the data that we include here on response measures is gathered from local media reports by ECDC staff. This is a non-high-tech data collection exercise. We looked at the agency, at the staff who represent every member state, and they were asked according to their native language and their country of origin to go and routinely, I think it's now the 15th time that they are assessing this data so that we can put it into the model. Next slide, please. As I say, the model is calibrated to data on disease incidence and hospital occupancy. When we do that, when we mimic up until today what has happened so far, we can estimate back the behaviour of people. We infer that from the data. So we make an inference on an average basis. How many people does one person come into contact with over time? And then separately, we compare that with data from, example, Google or telecoms companies, and we see whether what we learn from the epidemiology and from disease surveillance matches with what's being observed on people's phones. And here you see the mobility data for France. France there is in the top right panel of the model output. It's a very similar pattern. We find that it's possible to get at that trend from two completely different data sources. Next slide, please. The model is calibrated, as I say, using Markov chain Monte Carlo to cases, deaths, and hospital and ICU admissions and occupancy. And we do that in a way that the model learns from every country. So instead of just looking at the data for one country at a time, we try and learn what is shared, what is common across Europe, and where are there differences from one country to another. And that allows us to infer how much a certain policy might have an effect in one country compared with another. And when we have that nuance, it makes it easier to guide appropriate policy for the next stage and to think about higher, more targeted interventions spatially in a local level. Next slide, please. And then we put all the pieces together. We end up with something like this. We have data on the non-pharmaceutical interventions, on the policy in place, on the cases, on the deaths and the hospitalizations. And what that allows us to do is to make some forecast of what might happen next with a degree of uncertainty. But I think what we have learned this year in doing this is that we're really massively dependent still on personal individuals tapping in data, sending it online through our secure systems, even web scraping backwards to go and look for it. So the potential of this sharing or computer-to-computer transfer, the data lakes that are planned, is tremendous for the efficiency of being able to do this type of work. Thank you.
Thank you very much. Thank you very much, Helen. That's very interesting. Thank you for those insightful remarks and your experience of the last few months. Let me now pass the floor without much further ado to Nicholas Blomberg, who will now speak and his experiences with the Alexia organization. Thank you.
Thank you very much, and thank you for the kind invitation. Could I please have my slides up? So while we're waiting for the slides, so I'd like to say a few words today about the work that we have done in Alexia with all of our partners to share COVID-19 data. This is very different data to what Helen talked about. We are focused on the genomic and the biomolecular data, so the sort of detailed molecular footprint of the virus in Europe. But I think there are some useful learnings here, and I think it will point forward and be useful for the work on sharing genome data in general in Europe, and perhaps also some useful learnings for the creation of the European health data space. If I could have the next slide, please. So Alexia is a distributed infrastructure, is Europe's infrastructure for life science data. And we are an open science infrastructure. We provide access to a range of services for handling data. So the next slide, please. And these are assets that are used and produced by all of our member states across Europe. And next slide, please. And we serve the whole of the life science community, so from biomedical research to biodiversity. Today I'll talk about health, but actually the biodiversity work that we've done been really useful in COVID and has contributed to, say, better annotation of the animal hosts of the virus. Next slide, please. We are a distributed infrastructure. Next slide. Next slide, please. So we are a distributed infrastructure. We span hundreds of institutes across Europe in our 23 national nodes. And I'd like to describe, and I think that network aspect, the distribution aspect, is really important for enabling data sharing. We heard from Helen the challenges of annotating data and getting it out from local resources. And Kerry talked about the importance of connecting up our national assets. So I want to talk about how we've used this network to drive sharing for COVID and for genomics in general. So next slide, please. And I think this also is a really good example of how the sustained investment in research infrastructures pay off. And so if we can move forward, please. And this COVID-19 data portal, or the platform, I think really was a stress test. As Helen said, we needed to respond very rapidly in the early part of this year. So if we move forward, I'll talk about some of the details here. Next slide, please. So there are some real challenges when it comes to the COVID-19. But it was growing, so most European countries mounted a very fast response to the pandemic. For instance, in Spain, very early on, over 10,000 patients were genotyped. Germany, Netherlands, Sweden, many other countries have large sequencing efforts and cohorts ongoing. Next slide, please. And this data is generated in many institutes over Europe. It's using local resources, local capacity, local expertise, but that's also creating a challenge in finding the relevant data in all of the scattered and disconnected resources. Next slide, please. And we need to bring together all of that data with the experts from different disciplines and sort of help to integrate. Kerry talked about the need of bridging different data types for learning exercises. And I think that's one of the key aspects of the COVID-19 data portal. I think I could have the next slide, please. Yes. So there are, so together with EMBL EBI and our national partners, we've created a COVID-19 data platform. And I think there are three important components for this and a bit forward-looking. So the first is to look at the viral data. So how do we share the sequenced virus that are being assessed in institutes across Europe? It's the secure sharing of the human patient data, so human genomes and the response of patients both to the virus and to the treatment. And both of this data needs to be secured, it's access controlled, but it needs to be analyzed in the context of a large body of open data from all the open science reference databases in biology. So next slide, please. And we're bringing together and integrating this into the COVID-19 data portal, exposing data from a lot of different countries. So if we move to the next slide, I think this, next slide, please. So I think this brings me to the first point I'd like to make in this short introduction, that the reason why we could mount a rapid response was because we had a well-established network. And I think the existing projects and the existing research infrastructures really is a good foundation for the European health data space. Next slide, please. And this network is a network of infrastructure. So how do we connect the data resources to secure clouds, to federated analysis tools? Next slide, please. It's a network of data. So we need to help people to find that data. We make it fair, make it easy to reuse by scientists across disciplines. But most importantly, I think it's a network of people, and next slide, and a network of trust. And so what these existing structures have helped us to do is connect and help people to collaborate. And importantly, it's also helped to set up the guidelines that allow institutes to manage the liability and risks that are inherent in sharing personal data across countries and across organizations. Next slide, please. And we haven't done this alone, of course. There's been built with many partners. EMBL EBI, the European Biomolecular Laboratory, has been a key partner, and the European Commission have supported this through a large number of projects. So if we move to the next slide, please. So what we've established to share the COVID data, I think, is the same toolkit that's needed to share other personal data, such as genomes. And so in the Beyond a Million Genome project that we are coordinating, we will use these assets and the network to allow genetic and clinical data sharing across Europe. Move to the next slide, please. And so this is the second point I'd like to make, that the high-level member state commitment within the Million Genome Initiative is really key to progress. There are many complex legal and regulatory issues that can only be resolved by national bodies. And the investments needed to share data between a large number of institutes across Europe can only come from national roadmaps. So move forward, next slide, please. But this is my third point then, that we wouldn't have got this far without the European funding. So the European funding really built the synergy between the national investments in Elixir and within our other research infrastructure partners. So it helps to build a synergy between the national investments, but it also helps us to develop the collective capability, the capacity across Europe that we need to be able to connect data. So if we move to the last slide in a quick summary. So I think our work in COVID, in Million Genome, can support a European health data space. And importantly, I think it has shown three things that we all need. So the first is how we connect people and institute and infrastructure across countries in a way that engenders trust and collaboration. We need to connect the open and the access control data. And importantly, and I think Helen showed this really very well, we need to connect across a very large number of diverse data types. And that means bringing a lot of different communities together and have them to collaborate and understand the annotations and the details of that data. So thank you very much.
Thank you very much, Mr. Bloomberg. Now I'm going to turn it to Ms. Annette Madi Nator. I would ask both the last two speakers if you could be quite concise, because we are running out of time and we want to have some questions at the end. So if I could ask you to be as concise as possible in your speeches. Thank you. I give the floor to Ms. Annette Madi Nator now.
The invitation to this panel is quite exciting because I hardly ever get the opportunity to merge with mathematicians and experts from biological science. What was already told or mentioned within this panel showed me one thing, that the severity of this COVID-19 issue is quite high. And I also have the feeling that to a certain extent, the effect is a kind of emergency effect that the data scientist needs to handle somehow. From cybersecurity perspective, the picture is a slightly different picture. In the first part of my presentation, I will show you some statistics to reflect this. And in the second part, I will try to drive the attention to one certain issue, that there are still areas that need to be tackled within cybersecurity in relation to COVID-19 and alike issues. So can I have my slides, please? Yes, the first one. Thank you so much. So what we experience in relation to not only to COVID-19, but top cybersecurity risks that affect healthcare is that the top priority that needs to be handled is the human issue. There are still a lot of human errors unintentional, mostly unintentional, but in certain cases intentional issues that need to be taken into consideration when we analyze why the healthcare industry is so much affected by cybersecurity threats. There are some other areas that I will mention later on, so I can go to the next slide. Can I have the next, please? Thank you so much. Interestingly, as I already said, 2020 is not the most severe, for the first sight at least, not the most severe year from cybersecurity threats affecting the healthcare industry in general. Because, as you see in the headlines, the breached records is only, for this year, is only approximately a bit more than 80% to what we had last year. What needs to be mentioned, interestingly, for 2020 is that the severity, so basically the impact of these incidents, is much stronger, because there are actually a few number of large, really large, I could even say giant healthcare service providers, of which data, disclosed data, is more than of the others altogether. So the effectiveness, the pattern of effectiveness has changed a lot with the coming of COVID-19. Next slide, please. Yes, thank you. The particular types of data breaches also changed enormously. The most significant increase happened in 19, so last year, as you see again. But the impact of these incidents is much greater. As you see, the most affected part of the healthcare industry is actually the healthcare service providers. Next slide, please. Where did the breaches occur? It actually refers to the computing system, not the geolocation. So the data breach trends show that the most severe attack surface is the email. So we are coming back to the human again. Still, it is the human that provides the best attack surface, the best surface to attack, let's say. Next slide, please. As you see, we tried to somehow show you what are the most affected industry sectors in general that are affected by cybersecurity incidents. And if you count within the top 12, you can identify 2 industry segments. One is healthcare in general, and the other one is pharmaceuticals in general. So these 2 health-related industries are very much in the top 12 of those industries that are affected by, in this particular case, one particular case of cyber threats, which is ransomware. Next slide, please. And this is what I could even say, this is where the magic happens, because what the impact is of these incidents and of this phenomenon actually is the financial impact. And as you see, the average cost per record by industry sector is the highest when it comes to the healthcare industry. If you have a look at the average total cost of a data breach by industry, it's healthcare again. So the whole subject affecting the healthcare industry is much severe than those ones which we usually mention when it comes to cybersecurity incidents, like financial sector, energy sector, and industrial sector. So what changed with the COVID-19 from 2019 to 2020 is actually the price that we are paying for health data being compromised. Next slide, please. There is another issue that we usually mention and we want to drive the attention to, is that with the price that we are paying for the healthcare data compromised, it also takes the longest time in the health industry to realize that there is something happening from cybersecurity perspective in those systems. And the question is always why it's happening like so. Previously in this panel, it was quite much highlighted that the healthcare sector is the one that responds to emergency events, human-related emergency events. And what is actually the situation behind is that providing that kind of service is in the focus of healthcare industry, and how they provide that, what sort of IT systems they use to support this service comes somewhere in the background. So, but based on this data that we analyze from cybersecurity perspective, it's quite obvious actually that the infrastructure supporting the healthcare emergency and the healthcare COVID handling potential, and the healthcare and the virus research and development potential. So it's actually the IT background that needs to be given a bit more attention that we provide to that now. I believe I have no more slides to show. I just wanted to drive your attention to something else, though related. Actually, within the EU community, and I can also say that it's also true worldwide, there is only one shared database for the technical issues from cybersecurity technical perspective, where we can share COVID-19 related incident information. This is actually the COVID-19 malware information sharing platform. This is a community-driven information sharing platform, and that is more or less open source. What is available in this database is medical information, cyber threat related information, or cyber threat related abuse information related to COVID-19, and disinformation about COVID-19. So that's all what we have at the moment. We strongly recommend to set up not only a virus or medical related shared database within the EU environment, but to provide a centrally supported cybersecurity database as well, because it would help a lot. And it would also generate that kind of cooperation that seems to be missing now. Thank you.
Thank you, Annette, for that overview of the cybersecurity situation on the health data side. We have now, I'm afraid, only 5 minutes left in the session due to some technical issues we experienced through the session. So I'd like to ask our last speaker to talk in about 4.5 minutes, and then there'll be time for you to do a brief roundup. But we may not have time for questions at this stage, but it's important, I think, to hear from you, Mr. Petrovic. If you could take the floor now, thank you.
I appreciate that. I think it's very important to basically share the also industrial perspective on this important subject. It's a great pleasure for me to participate in this panel and stress the importance of data in healthcare. While we are getting my slides, I would like to give you my main message, and it's very simple, basically as the title of this panel. So yes, dear ladies and gentlemen, we need data for our health. Our lifestyle and medical care together determine around 70% of our health. To improve each of these, actually, we need data. And as you can see on this slide, we are getting this data actually. So we get the data, we can track our activity, we can track our vital signs, etc. Next slide, please. But why is data important? Obviously, it's important because we use data to create new medical knowledge. We can create insights about our own health. But data also helps companies such as Philips to create innovative solutions which healthcare providers use to save lives in real life. So it's important to realize that these AI-powered solutions can be created only if access to large sets of data of a proper quality is arranged. Next slide, please. I'll give you an example on next slide. So it's an example from Philips. So it's about a system that helps actually to predict whether a patient in a general ward will develop critical condition. So you can say in the next 2-3 hours that the patient will develop critical condition and alert the doctors basically to take proper action. So that obviously helps reduce mortality in hospitals, ICU admissions, severe adverse events, etc. But that's only possible because as a company we had a lot of ICU data, a lot of vital signs, as well as the outcomes of these patients, and we could put this together and create with machine learning these prediction algorithms. So that's the importance of data, and that's why we need to bring all this data together. If you can move to the next slide, very briefly, I would like to actually talk. This is a nice example also how we help in COVID. So and the importance of data in the COVID situation. So basically, we see in different countries that we have a sort of small places where we have a lot of patients. So we need to move patients from hospital to hospital. So we need to arrange exchange of data of these patients, because data needs to go together with the patient to another hospital so that this patient can be treated in the best way. So there is a nice example that Philips and the Dutch Ministry of Health come together and created this infrastructure to exchange this data across the Netherlands. Next slide, please. Then I would like maybe to, because there is not much time, I wanted to talk about challenges, and I'll very quickly go, if you go to the next slide, over 4 challenges that are very important. So if you move to the next slide, just 4 challenges. So we need to unlock the value from data which is held by public sector, by hospitals. So that's very important. So we need to bring this data, harness large volumes of data to be able to develop these products. We need to make easier for individuals to allow the use of data they generate for the public good. So we have to raise awareness of them, that they understand the benefits of sharing data which will bring to society, which they will bring to themselves as well as their family members. Standardization, interoperability, also very important, as well as the infrastructures, and Gaia X is a nice example of helping in this process. So finally, I would like to mention the final slide. I would like to mention that and bring your attention to upcoming public-private partnership of AI data and robotics, which is initiated by BTVA, Claire Ellis, EuroAI, and EU Robotics, and addressing the challenges I mentioned. So and this relies on the adequate level of investment of European Commission so that we can actually resolve these challenges. So please join us to shape the future of Europe.
Thank you very much. So thank you very much to you then, Milan, and to all the participants. I'm afraid that time and technical issues have been our enemy here in terms of really having the chance to further explore some of the rich material that you've provided to us today. But I'd like to thank all of you for sharing with us your insights and your experience in this valuable topic. I think this is a deep topic. We need to create more of these kinds of sessions so that we can really explore in detail. I think just as a conclusion, we started 2020 knowing how important the health data was to the future of our healthcare systems, to the future of health outcomes. I think COVID has been a very powerful illustrator of just how valuable it is, and that we've learned in real time that we can do more things than we thought we could. And I think the conclusion really to the Commission and to me in this session is that we need to go forward now and intensify and accelerate our actions in this regard, and really spend the rest of 2020 and 2021 and beyond putting in place some solid mechanisms to improve the state of data for health in the European Union.